of the journey of how we should manage aortic stenosis in this modern era. Okay. So what's changed in the last decade is that the community is expecting different things from us than what we were providing to them in the 1990s and the 2000s. People in general are living longer, and the word inoperable for valvular heart disease is almost never said now. Now, I can remember back in the day having people basically finish their life with end-stage, particularly aortic stenosis, and it's an awful way to end your life, breathless, recurrent pulmonary edema, but it was all we had, and morphine and palliation was really the only option. But the word inoperable has become progressively more intolerable or unacceptable to our community. And therefore, is there really such a thing as end stage? And I'm sure there is, but the goalposts have moved a long way towards the right in terms of what we can do for people. And the other thing is that people have become progressively intolerant of the idea of stenotomy. And so double inverted commas keyhole surgery, which is what the community refers to all these clever things that we do percutaneously, has now become a norm. And the expectation that folks won't have to have a sternotomy is ubiquitous. So how did we get to where we are? Well, everybody will remember stories like this of these valves from yesteryear, which took a fatal end-stage, unsurvivable condition like aortic stenosis and turned it into something that you could survive. And most of these things started as mechanical. Now, here's something I've always wanted to do, and that is put a slide of me up on the monitor. But this is a Star Edwards valve that a man gave me. This had been in his heart for 40 years, popping away, ball and cage style of thing looked like a snorkel. And the thing about these things is that they were really an incredibly wonderful thing. And some of us, particularly you Sydney folks, still have some of these devices. In that picture on the left, it's a mitral because it showed up nicer. But the concept was that these things worked very well, and they turned a fatal condition into something survivable. The problem with these is they required very high warfarin levels, and they had very high gradients. But for those of us who looked after them, some of these things are still in 40 years later. So the decision to go to surgery now, which back in the old days was a big decision because the operating mortality was high, and now has changed dramatically because of the things that we can do which are less intrusive, or the things that are intrusive we can do at lower risk. Now, every single aortic stenosis talk ever in the history of mankind has had this slide, which is the Brunwell slide from 1968, which showed something like this. That is, you keep going and you keep going and you keep going till you don't. And when you don't, when you get angina or heart failure or syncope or edema, then your mortality is very high. And we all live by this dictum. And that was in your 80s for calcific and probably in your 60s if you're bicuspid. But nobody lives like this anymore. Because what happens now is we don't wait for people to get profoundly symptomatic or in trouble. What we do is, and we're not talking about survival now, we're talking about when you go to surgery. And by surgery, that can be operating or percutaneous. And we don't talk about age anymore. We talk about gradients or valve areas or some other dynamic, but not just how old you are. At the end of the day, you keep going till you can't, and then you have to make a decision to go ahead and do some sort of procedure. Now, what happens is we get these folks coming to us at various stages of their life, young, middle, mature, and stately, and I feel like I've just moved from mature to stately myself just now. So I put this picture up because the young ones are mostly bicuspids, and that picture on the right there, Steve, is our first 3D echo, which was done maybe in 1997 or something with a Tomtec device. And in that picture there, just for your reference, that's actually 60 2D slices sliced together, which had to be taken on one breath hold, which means that took 2 minutes and 30 seconds to acquire or something. And so what I used to do, Steve, is I used to get the fellows to hold their breath for the whole duration of because the patient had to hold their breath, so I got the fellow to hold their breath. And as they were falling over, usually we press the acquire button. So anyway, that was a picture of bicuspid aortic stenosis or bicuspid aortic valve disease. And the treatment of those were these things, and still is for the young ones. The mechanical aortic valve, which these days are these bi-leaflet tilting disc devices, an incredible piece of engineering, which I have a man I saw the other day has got one in for a long time. We calculated it had done 11 billion heartbeats, but requires full warfarinization for the rest of your life. They work very well, but warfarin is no small thing, and everybody knows about the issues, but they last and last and last. So they truly would be the gold standard for managing aortic valve disease in young ones. When you do this, make sure you put in a big enough valve. This is to the surgeons, because this whole prosthesis patient mismatch, PPM, is a big deal. Once you put in a plastic valve for the rest of your life, that valve area, which is the purple on that diagram, is the valve area. And it's the valve area the day that it comes out of the packet. And if it's too small for you the day that it goes in, it's going to be too small your whole life. And you're basically going to have the equivalent of aortic stenosis your whole life. So when we put in these prosthetic valves, we try and have a valve area of greater than 0.85 centimeters squared per meter squared. So if you're a 2 meter squared big bloke, that means you need to have a valve area coming out of the packet of 1.7 square centimeters. So it's a big deal because you're committing to these people to a device for life. And the other thing you're committing to life is warfarin. And warfarin is a revolution and a problem all at the same time, with simple and then more dramatic consequences. You can't eat greens, or if you do, you have to eat the same amount every time, every day. You get this staining, and of course, the most feared complication of this terrible intracerebral hemorrhage. So warfarin is livable, and many folk do live with it. Nobody wants to live with it, but it's the only way at this stage that you can have a plastic prosthetic valve, which we would say has got the longest chance of living, of longevity for a young one. Now, the thing about it is that everybody's looking for solutions for people in the middle age, young to middle age bracket, which don't require warfarin. And we went through a phase of putting allografts in. So these are human donor valves on the left there, taken within 24 hours of loss of life. And these things are implanted. In fact, that forceps is holding the mitral valve of the donor, and the mitral valve is donated with the aortic root. Unplug the coronaries of the person and plug them onto this thing, so end-to-side connections. And you end up with a thing on the right, which you couldn't tell is not your own aortic root. And a wonderful solution, and championed in this country, Steve, we championed this in Brisbane with the cryopreserving. But the problem is that late down the track, they calcified badly and hard to get out. Then came these two men, which seemed like unlikely bedfellows, so Donald Ross and, of course, Arnold. The Ross procedure, invented in the United Kingdom, took that same allograft valve and plugged it into the pulmonary position, unplugged their pulmonary valve and moved it to the aortic position, unplugged their coronaries from their own aorta, which is thrown out, and plug in the coronaries into their own pulmonary autograft, with the concept being that the thing that you're putting into the high pressure aortic position is living. And so you're your own donor, and you're a donor of a living valve into the aortic position with your coronaries plugged on. And they're wonderful. But the problem is, of course, that you turn a one valve problem into a two valve problem. And again, this is one of my Ross folk. You typically use this in young women who want to have babies down the track. Of course, you can't have warfarin in that situation. And a beautiful operation like this. And again, you'd never tell that that's not just a normal aortic root there. But you also have now a PVR, an allograft PVR. And we do have some problems with these down the track. They get stenotic and they wear out. And in fact, our most famous of all these people, if it's coming up, Arnold had to have his pulmonary valve reoperated a couple of years ago, having had his Ross procedure back in the mid-90s. So it's a lifetime journey of procedure and redo procedure, and that's, of course, where we're going next. So when the folks come to us now in the middle age and onwards, and now we're talking 40s, 50s, 60s, nobody wants warfarin. And most people won't be wanting a Ross, although some will. And everybody says, can't I have a pig valve or a cow valve? Let's call them animal valves. And that's an example there of a Toronto valve. And here's an example now of a full pig root replacement called a freestyle valve. So animal valves have evolved a lot. They're much better than they were. And in fact, we've largely abandoned pig valves and mostly they're cow valves now. And these valves require no blood, no warfarin, typically aspirin, and have longevity, which is in the order of 10 to 15 years. Now, 10 to 15 years when you're 70-some is okay. 10 to 15 years when you're 50-some is not okay. Yet nobody wants warfarin. So this is the tug of war we're playing every single day in managing these aortic valves. Here are some of the modern xenografts, the trifecta valve, the Inspiris valve. There's a variety of models now, MitraFlow and still perimounters around. There's lots of different valves models, which as echo folk we'll see. But the fundamental is that they've got 3 struts, and the struts have 3 leaflets, but the leaflets aren't leaflets. They never were leaflets, and they never were a valve. They're pieces of cow pericardium that are suspended between the struts, a bit like you might hang sheets on a clothesline with 2 pegs at either end. And so the material is cryo or otherwise fixed, and the concept is that they have the lowest profile possible. Now, you put in a valve, and a youngish one, which we would not have done in the old days. We would have forced the issue of putting a plastic valve back in the old days. But now most folks in their 40s, 50s, 60s don't want a plastic valve. So you put in a valve which you know has got a finite life in a person who's got a longer life than that, and then you have to deal with what you're going to do with down the track. Because the younger you are, the faster you wear these things out. Your heart is powerful, you're more vigorous, you're having more heartbeats, doing sport, and so the wear and tear on xenos is more in young ones. And so you get to this thing, often at not that old of an age, where you say, what are we going to do with a failed valve? Are we going to reoperate, which again, nobody really wants? Are we going to do a valve-in-valve, which is ubiquitous? And so what do we do? What's a valve-in-valve? Well, if one of these valves starts to fail, either leak or become stenotic, we try to put a valve-in-valve in. If you look at that graphic at the top right, that's one of the newer Xeno valves, which is pre-built to stretch. See the slip ring there? So that when you put the valve-in-valve, you go, if it's a 25 millimeter valve, you can put a 25 millimeter valve in it because it stretches at the time of the event. It's engineered in advance for next time round. People are thinking now about the lifetime journey. Unfortunately for the world, most folks don't have this yet, and we have to either compromise by putting a 23 into a 25 or whatever, like the Russian dolls concentric circles thing, or we try and crack the original valve. But whatever it is, we then go ahead and put a pretty typical TAVI valve inside the failed Xeno and leave behind. And this is a wonderful procedure. This is an operation that does not require sternotomy. This is almost day surgery now and gives a solution for these people. So now you've got valve-in-valve, and you might have a person who started in their 50s and now is in their 60s, but what happens when they're in their 70s, which we've not quite got to? Are we going to do valve-in-valve-in-valve? We're going to take the whole lot out when they're 70 and put another Xeno in. This whole journey about what we're going to do in the non-warfarin environment that we live in now. So here's an example of putting one of those valves in. Look at the ring of the Xeno valve. You can't even see the struts. This heart is being ventricular paced very fast so that it's standing still. And that TAVI now is sitting beautifully as a valve-in-valve. This is a great procedure. And it's a temporizing procedure. It gives you another decade. What do you do at the end of that time? To be announced. A couple of times we've had problems where the leaflet of the Xeno valve, for the first time in its life, is now to be held open. So a Xeno valve is usually closed in diastole, which we just learned is when blood flow is. But for the first time ever, those Xeno leaflets are going to be held open by the TAVI frame. And so now you've got a thing where you've got a wall or a curtain of Xenograft valve leaflet right in front of the coronary orifices. So we do these things like basilica, which are things where we tear on purpose a hole or a slit in the leaflet so that we're making a doorway, something like that, for flow to come through the side of the TAVI valve, through the now torn leaflet of the Xeno, so it can get to the coronary orifice. So the community now has really abandoned the thought of having their chest cut open for any kind of heart surgery, basically, and everybody wants that keyhole job done. And that's fueled because we've done so well with this and also because of the media. So this is now the elderly folk who come to us, and this is very typical, this lady gave me permission to use her picture, came to us with pretty much our usual demographic of people coming for elderly intervention and severe symptomatic aortic stenosis. So how do you manage this? Well, what you do is we universally put people through our heart valve team. So back in the old days, it was one doctor, one patient, one doctor, one surgeon, one operation. And now it's the people come into the process and they're referred to not a doc, but to a doc who then goes into the program. And there's a very good reason for this because there's a lot has to happen to make this go right. Lots of things have to be considered, like the arterial access, like the lung function, like general frailty, like cognitive function. Lots of things have to go right because whilst the procedure is relatively straightforward, this is a frail, usually elderly human being. But when you put a TAVI in, which I think is one of the best things that we've ever had in medicine, in terms of medical engineering, you take severe aortic stenosis and you turn it into a sorted out situation in about 20 minutes these days, and usually home the next day, like that. Now, what do we do when they start failing? Because TAVIs are going in younger now. And so people in their 60s are saying to me, I don't want to have heart surgery. And we say, well, heart surgery is still the gold standard and come back another day for a TAVI. They say, I don't want to come back another day. Well, I'm happy to come back, but I don't want to have my chest cut open the first time. And so now the younger ones are asking us for TAVIs. And what do you do with that? Are we going to be able to do TAVI and TAVI? And then David, maybe TAVI and TAVI and TAVI down the track. And David's nodding because he likes doing TAVIs, but the thing is that it's not, is it a bottomless pit? Can we just keep doing this forever? Because that's what people are going to be asking us for. So to summary, the lifetime journey of people with aortic valve disease, when they come to us for their first procedure, what do? Mechanical valves are still the gold standard, almost unsellable now as a concept to people, but a few of these are still going in. Do we put a xeno in surgically into a youngish person? Probably still the way to go in this day and age if you're not going to put a plastic valve, or maybe a Ross. But put a xeno in to give a firm foundation for what's going to come next, and probably put in one of these modern xenos which is stretchable. Or do we do a TAVI in a young one? I don't think we're there yet. I really don't feel like it's that anybody is going to be at this stage comfortable putting TAVIs in younger ones like that. But then second time round, do you do redo surgery, put a TAVI in the xeno valve, you take out the xeno and put in another one, so on and so on. And then third time round to be announced, because this process, we really are, I feel, at second round now. So we've got all the first round, lots of first round xenos, lots of first round TAVIs coming towards the end of their working life. We're in second round, we're doing lots of valve in valves. We've done some TAVIs in TAVIs. The third time round, it's to be observed how we're going to handle the technology at that stage. Thank you very much.